On November 9th, 2018, I saw Mr. VC, who's a 38-year-old Caucasian male, in Surgery Heart Failure Clinic complaining of shortness of breath, dyspnea, and chest pain. He had been referred from his cardiologist, Dr. Brown, for surgical evaluation. The patient has a history of hypertrophic cardiomyopathy, diabetes, and hypertension, and he explains that he experiences chest pressure, lightheadedness, night sweats, fatigue, and shortness of breath on a daily basis at rest. These symptoms are exacerbated when he exerts himself, when he goes to sleep at night or lays down, and may become progressively worse over the last 6 months. The patient explains sitting in a chair that his chest pain is 5 out of 10, but when he exerts himself, it can become an 8 out of 10. The patient was diagnosed with hypertrophic cardiomyopathy 2 years ago. Since then, he's been diagnosed and worked up by his cardiologist, Dr. Brown. Reports a little bit of noncompliance to failure to obtain and hold insurance, but he does report insurance at this time. The patient is currently on metoprolol, but he still is reporting these symptoms. He had a septal ablation 1 year ago. Unfortunately, it was not able to be successful to treat his symptoms as well. Other surgical history includes a appendectomy in 1999 and a rotator cuff repair in 2014. The patient is on full disability. He lives at home with his wife and his children. He denies alcohol and drug use. He does admit to smoking 7 cigarettes a day and has a total of about 11 pack-year history of smoking. He denies hemoptysis, palpitations, headache, and cough, and he denies a history of stroke or heart attack. Patient does not allergy to tramadol. He's currently on metoprolol and Trulicity for his diabetes. Vital signs: he was a little tachycardic with a pulse of 108, and he did have elevated blood pressure, 130/92. Everything on physical exam was normal, except for one finding, a systolic murmur found on the left sternal border when I listened to his heart. Lung sounds were great, no adventitious sounds. The patient was worked up, like I said, by his cardiologist previously, so I reviewed his labs and everything that had been done at this point. He looked at CMP, CBC, PT, INR, PTT, A1C. I wanted to make sure that if we ever had to do anything emergently, he wasn't going to bleed out on the table. PT, INR were all in normal limits. The only thing elevated was his hemoglobin A1C and his sugar, which was 251 and 7.5. The diagnostic studies had shown EKG, left ventricular hypertrophy, and dilated left atrium. The cardiac MRI also showed that, as well as asymmetrical severe hypertrophy of the basal to apical septum and basal to mid-inferior wall, consistent with hypertrophic cardiomyopathy, as well as a hyperdynamic left ventricular systolic function of 75% ejection fraction and greater than 70% on the right side as well. There was a scar at the basal septum at the anterior inferior left ventricular insertion sites, common with the pattern of hypertrophic cardiomyopathy. Systolic anterior motion of the mitral valve was also shown, which was consistent with the systolic murmur I heard on physical exam, and he did have dynamic left ventricular outflow obstruction. Echocardiogram showed the same thing: severe concentric left ventricular hypertrophy. There was abnormal left ventricular diastolic filling, consistent with LV diastolic dysfunction and relaxation. My assessment and plan: I diagnosed the patient with obstructive hypertrophic cardiomyopathy, which was also diagnosed before. I was evaluating him for a septal myectomy, which I thought he would be a great candidate for, considering his symptomatic symptoms right now and his previous alcohol ablation failure. I had planned to discuss with the other cardiovascular surgeons a plan to go about the surgical reduction of the septum, as well as to inform the patient of the risks of the procedure, which include ventral septal defect, different arrhythmias, infection, and bleeding. I also want to get his sugars under control. I billed for the diabetes, hypertension, as well as him being overweight. In terms of follow-up, I was going to call the patient to address these concerns, the surgery, timing for that. I was also going to order PFTs, chest x-ray, carotid ultrasounds to make sure no other issues were going on, and of course posting to the OR.